A very good morning to you. I'm Howard Feldman. This is the Synthesis Sunday podcast with me, Howard Feldman, and pulmonologist and specialist Dr. Anton Meyberg. It is the 6th of June in South Africa. We are in the midst of the third wave, and I'm not referring to Eskom. I am referring to COVID-19. It is cold and miserable outside. Actually, it's not. It is cold. It is not miserable. The sun is shining. It is a beautiful day, just a very, very cold one. Clearly colder where Anton Meyberg is on the other side of the neighborhood. Good morning, Anton. How are you?
Good morning. I'm much warmer because I'm wearing my beautiful inscribed jacket, and it's a good way to start off the podcast. Let's
talk numbers. How are we doing?
Currently sitting at 173,729,856 cases worldwide, with 3.7 million deaths and 156 million cases resolved. The United States has 34.2 million cases with 612,000 deaths. India creeping up at 28.8 million cases with 346,000 deaths. And South Africa on 1,691,491 cases with 56,929 deaths and 5,451 new cases in the last 24 hours, a 13.5% test positivity rate, as well as 1.2 million people having been vaccinated, which is pretty dismal. Currently, there are 3,042 cases in Gauteng, with 739 in ICU and 326 on ventilators. And the Northern Cape has the highest weekly incidence of 157 cases per 100,000 people. Now, just to try and explain it a bit better, if we look at that Hatsola numbers in the last 24 hours, there's been 26 new cases just on the Hatsola numbers. So you've said a good point that we're in the third wave. Now, if you read any of the literature or any of the articles that say we're entering in the third wave, I completely think that's completely wrong. I think we are definitely in the third wave. There's no doubt about it. What we're seeing at the hospitals, what we're seeing around us, it's just a matter of when we're going to hit the peak, and that we don't know yet.
All right. Can I just tell us what's going on at your hospital? I know because we speak every day just how horrific your week has been. But give us a sense of what's really going on there. How many wards are open? How many people in ICU? I don't know if you can talk about the losses that you've experienced or patients families have experienced. But give us a sense of just how hard this is.
So we're now in that war zone. There's trenches being dug around the hospital, literally and figuratively. We've got 5 wards open in the hospital. The ICUs are full. We've had tremendous loss this week from a community level. We've had lots of deaths of people who have been critically ill and those who haven't been critically ill, that have just died from the disease. It's been a devastating week. It's been a hard week. It's been an exhausting week for the medical personnel and, of course, for the families who've lost loved ones. We speak a lot about the fact that, hospitals are closed or they're on divert, and I don't think people really understand what that actually means.
What does it mean when you tell us that there aren't beds? What does it actually mean?
So when we go into divert, what it means is that if, God forbid, someone has to come in with a heart attack and we're on divert, it means that if you live in the greater Glen Hazel area and Linksfield and Moore Park and Bedford and Sunninghill on divert, you might hopefully find a bed in Pretoria. So you might have to be transferred all the way to Pretoria to find a bed. But it means there's no beds. There's no bed availability. There's no ICU bed. There's no ICU staff. There's no ventilator available. So for chronic conditions or acute critical conditions, there are no beds for patients that need to be in hospital. And the only way we can prevent that from happening is to go back to basics and prevent.
A few people have asked the question around the fact that although the national numbers are not yet as high, I think we're around about the level of the first wave. Why are the hospitals so much fuller this time at this level?
So that is a very good question. But if you remember this time last year, we were in complete lockdown. People weren't allowed to leave their houses with certain amounts of freedom. There was a higher level of lockdown. And we found that people with chronic conditions weren't coming to hospital. So the hospitals were full with COVID cases, but we weren't seeing the regular people with high blood pressure, with diabetes, with emphysema. Now, across the board, we've got half the hospital full with chronic normal conditions, in inverted commas, and the rest of the hospital full with the COVID conditions. We don't have a bed availability. Never mind bed availability. We need staff to staff those people. And you've got tired nursing staff, you've got tired auxiliary staff, people who aren't coping anymore, and we just don't have the availability of that staff to man those beds.
I've also heard it mentioned that kids are getting sicker, not with COVID, but with other stuff this year. One of the theories being because last year they weren't at school, they didn't pick up those normal child illnesses, and they're suffering a little bit more this year. Has that been your experience as well?
So you're right, but there's two edges to that sword. Firstly, kids are getting sicker and kids are getting more positive results with COVID, what we're seeing from the second wave. And we're looking at the third wave. Now, if we look at that solid numbers, there's a larger number of kids who are testing positive. And we've said this before, we're seeing it in families that not one person gets sick, multiple people in the family get sick, whereas in the first and second wave, it was maybe one spouse and nobody else got sick. So we're seeing multiple members of family getting sick. At the same time, last year, we didn't see one case of influenza A or influenza B. Now we're seeing influenza A, we're seeing influenza B, we're seeing respiratory syncytial virus, RSV, adenoviruses, noroviruses, all other viruses that are common at this time of year that we weren't exposed to last year because people were locked up and kept away from each other. So these are the natural viruses during your winter period that will come about, and these will infect people, and we're now going to see them. And obviously, these kids who weren't exposed last year will have a higher predilection to getting exposed this year because they've got a different altered change of their immunity, which they didn't have the year before.
Very, very interesting indeed. I see that there's been a reference or a change to the names of the variants. Firstly, are we seeing anything different with this third wave in terms of variant? And secondly, tell us about the names that are acceptable to use nowadays.
So we still think that we may need dealing with the B1351 variant, the formerly known B1351, the South African variant, and that's the predominant variant we're seeing in South Africa at the moment. There's a new nomenclature, a new name for the variants. They're going according to the Greek alphabet. I'm not sure why, but apparently when they run out of letters from the Greek alphabet, they'll change to one of the other alphabets. Who knows which one? So the B117, which is the UK variant, is now being known as the Alpha variant. The B1351, the South African variant, is the Beta variant. The P1 Brazil variant is now the Gamma variant, and the B1617 is the Delta variant. These are seen to be nicer names and more politically correct. So when you talk about the Alpha, Beta, Gamma, and Delta variants, you aren't singling out single countries. It's a bit of this and that. But what the World Health Organization has also done, they've also basically made it into what they say a virus variant that is a variant of concern or a variant of interest. And a variant of concern is one with an increase in transmissibility, an increase in virulence, and a variant of interest is one that can cause community transmission. And remember, we must know that a virus variant happens when there's a number of new mutations that occur with that virus.
Right. Well, personally, I think we should have been the alpha virus. I've never seen an alpha Brit.
It's like they're like the alpha male, alpha virus.
Exactly. South Africans are not beta. We
are kind of like the beta max. I don't think we're at that VHS level yet.
Oh gosh, I can't go there. All right. So but at this stage, it does look like what you're seeing is similar. It's behaving in a similar fashion to what is now called the beta variant.
It is behaving in a similar way, but not really. As I say, we're seeing far sicker people. We're seeing a group of people that this sort of in the second wave weren't as sick. I think if we look back to the first wave, the people who were really sick were the 75 to 85-year-olds. If we look at the second wave, it was kind of the 70-year-olds and older, but we already started seeing a new wave of younger people, like 40-year-olds, 45-year-olds. And now in this third wave, we're seeing almost like there's people of the age of 65 and older that are getting much sicker. It seems to be affects them, those with comorbidities, those with chronic conditions. So there seems to be more virulence with the same variant that is spread and is causing more havoc in younger people. And the sort of the age group is going down. And there are multiple reasons for that we can kind of sort of hypothesize. First of all, we're keeping all the elderly people locked up in the old age homes. We're now starting to vaccinate some more of the elderly people. And that's got to help. That's got to change the virulence of the virus, not attacking the older people, but then it's got to go somewhere else. So then it goes down the line to the younger people. And that's what we've got to be seeing. And that's why it's so important that we've got to get everybody vaccinated. We've got to get this vaccine rollout more effective, quicker, and a bigger rollout as possible.
A number of people have mentioned that it seems to be almost sort of 65, 66 through to 75 are suffering higher mortality. Is that an observation as well?
Definitely. We're definitely seeing that. And once again, I think it's the same reason, because even though we are seeing elderly people, as I said, the older people are being locked up. The 60, 65-year-old people are going back to work. They're starting to re-venture back into the world. They're going to be exposed. People have got pandemic fatigue, lockdown fatigue, and they almost think they're infallible, that they can't get it themselves. You know, people always believe that they're so safe and they're so good, but they don't realize that they're not following the rules. They're doing what's good for them at the time, and these aren't always the correct procedures.
What are we seeing in terms of people that have been vaccinated and positivity in terms of COVID?
Yeah, that's a very important point as well. You know, once again, we've said all the way from the beginning, just because you've been vaccinated does not mean you are safe. Once again, let's reiterate that. If you have been vaccinated, you are still not safe. In other words, you can still get SARS-CoV-2, or you still can get COVID-19, albeit at a lesser virulence, or it won't be as serious as before. We've seen a few people in our hospital that were vaccinated, that were quite ill, but thank God managed to get out of hospital. So we haven't seen any deaths from it. But once again, you still can get the virus and you can still transmit it to other people, even if you've been vaccinated. Go back once again to the flu vaccine. Even if you've had the flu vaccine, you can still get flu, but it prevents you from landing up in ICU. So whatever vaccine you can get, whether it's a Johnson & Johnson or the Pfizer, get it, take it, and run with it.
So at this stage, you have seen people that have had the vaccine landing up in hospital, small numbers. Have any of them landed up in ICU?
So I've actually seen one of them who's been fully vaccinated over 6 weeks and then land up in ICU, but only one. That's a very small number. Multiple people have been vaccinated, but when they say they've been vaccinated, they had their vaccination, let's say last week, Monday, and on Wednesday, they're admitted to hospital. And that's got nothing to do with the vaccine. That's got to do with the fact that they were either exposed or they had COVID already when they had their vaccine. And that's a very important point to make as well.
Are people that, do you get sicker if you've got COVID without realizing it? You go for the vaccine, and then you know what? Then you start to become symptomatic.
So that's an interesting point, and it's quite an anecdotal point. But from the ones we've seen, the people who've had the vaccine and then had COVID 2 or 3 days later, they are very sick. And that's why we say if you've had COVID-19, if you've had a mild disease, then you should only have a vaccine 2 weeks later. You've had a moderate disease or moderate to severe 1 month later. And if it's very severe, if you've been in ICU in hospital for a protracted period with long symptoms, wait even up to 3 months. So you should have a waiting period between the vaccination and having had COVID.
Right. And of course, a very difficult question, one that I'm hesitant to ask, but I think we have to, because this is what we're talking very realistically, is what is the percentage of people that you put on a ventilator, that you have no choice but to put on a ventilator, that can come off the ventilator having recovered?
Look, I think it's a very difficult question, because it's a very broad question that you've got to look at the person's age, you've got to look at the comorbidities. But the older the person, the more comorbidities. Once they go into ventilator, the prognosis is very guarded. In other words, it means it's going to be very difficult to get them off the ventilator. And the success rate worldwide of getting these people off ventilators is extremely low. And that's the reality. And that's the whole point of this, is that you've got to prevent the disease from happening. You've got to be safe. You've got to look after yourself, because you don't want to land at the position where you need to land up on a ventilator. We're not saying that everybody who goes on the ventilator doesn't come off, but the majority don't, and that is the reality. This is a disease that totally decimates the body from an endothelial level, from a respiratory level, from a cardiac level, from a neurophysiological level. It destroys your body. It destroys your lungs. It destroys your cardiac system. It destroys every metabolic known avenue in the body, that we know about. And yes, there are certain elements that you can do. You can try send the patient for what we call ECMO, which is extracorporeal membrane oxygenation, which is almost like a bypass machine. But even that has limitations. You know, the sicker the patient, the more difficult it is to try and get them onto that sort of modality. And once again, I'm going to go back to the wonder maneuver or wonder mechanism of certain doctors doing bronchoscopies and sucking out the virus with mucus. That doesn't work. It's something that's been made sort of sensationalized by the media. If it worked, we'd do it. If it does work, it's maybe 1 in every 1 million people, if that.
So what is your current treatment? Is it pretty much the same as it was for the last wave?
I think our treatment is the same, but I think the mainstay of the treatment is the fact that we give patients corticosteroids, we give patients anticoagulation, we give them the whole vitamin cocktail, we, if necessary, give them drugs like tocilizumab, and then we offer them high-flow oxygen or CPAP or non-invasive ventilation, and as a last step, we do the extreme sort of serious ventilation. Now, what we did see in the first wave was the hydroxychloroquines and the azithromycins. Those have fallen out the way. In the second wave, we saw the ivermectin started coming up, as well as we were using remdesivir. We're not really using remdesivir at the moment because it's only found to be effective if you use it basically on day one of the person getting sick. If you're going to use it down the line, it's non-effective. So it's got to be used extremely early in the treatment of the patient in hospital. And as you know my feelings on ivermectin. We don't not use it because we don't want to. We don't use it because we have no evidence that it gives any benefit in any of our patients.
All right. Let's just take a look at some. We have answered quite a lot of the questions already just in the discussion, but there are some that I'd like to get to. If one has COVID antibodies, this is from Michelle, if one has COVID antibodies as the second variant, what will the vaccine give you that your body hasn't developed already? Is this current vaccine worthwhile getting if one already has antibodies? I think it's an interesting question.
So you've got to understand, if you've had COVID, it's almost like a first exposure, like a taste test. Your immune system sees the COVID and responds to it, but it doesn't build up a very strong memory response. And the circulating cells that you have developed from it are not enough to cause a rapid response to infection. Some people who've had COVID, although don't even mount a response, they don't even get an antibody response. But most importantly, the antibody level that develops after vaccination is far higher than the natural antibody level after a natural infection. And that's very important to know. And as Anthony Fauci has said, that higher antibody levels produce a higher cushion of protection against the variants. So that's a very important thing to note.
Right, and Simon wants to know, I have COVID-triggered osteoarthritis. It is still not under control, and I have had something block injections. I'm not facet block injections, etc. As such, I've been advised against the vaccine as it can apparently intensify chronic COVID symptoms. What are your thoughts?
So I think we've got to also go back to the thing. Osteoarthritis is not a common trigger or side effect of COVID itself. You can get myalgia, you can get joint pain, and there are very sort of anecdotal cases of psoriatic arthritis and arthritis. But the major reason why people get flare-ups of their arthritis is because either they've stopped their medication that they're on chronically around the time of getting sick, or the fact that they're using non-medical guaranteed medicine that shouldn't be used at the same time. Generally so, you would not say to people, don't have the vaccine. More so, all the studies are showing that people with the post-acute sequelae of COVID-19, in other words, the long-term events, actually benefit from getting vaccinated, and it helps decrease the consequences or helps decrease the inflammatory responses that develop from COVID. So we would advise people, even with a triggered osteoarthritic picture, to have the vaccination.
Interesting. Martine says, if a person has had COVID previously within the last 2 months, can they still carry and transmit the virus to others? Not from the original virus, obviously. She means reinfection.
So the answer is yes, they can. Okay, first of all, we don't know what variant they had. And second of all, we don't know what a person's immune response is or how their immunity adapts to that infection. So have they developed neutralizing antibodies? Have they developed an adaptation of their body that will actually destroy and break down the virus if it comes in again. And we don't know that. So at this point in time, we still say that they can transfer it. And that's the same reason why even someone who's been vaccinated in this country, if they're exposed to somebody with COVID-19, they still have to go into isolation and quarantine. We're not talking about la la land like Israel, because that's la la land to us. Okay, we don't have herd immunity here. We don't have the majority of the country being contained or vaccinated. We're talking about in our country, we've only got 1.2 million people who are vaccinated. And of those 1.2 million, half of them have only had one of the two vaccines.
Right. Merle says, I had the J&J vaccine. 2 weeks later, I had TIA. What is your opinion on the likelihood that that is connected?
Look, it's kind of the case of which came first, the chicken or the egg. I don't think we'll ever know if the TIA was from the vaccine or if it was a result of something else, what other chronic medical conditions you've got, what are your risk factors. It is not likely that it's from the vaccine, but it's not improbable that it can be because of the vaccine, but it's not high up on the list of consequences or side effects from the vaccine itself.
A number of people asking about the safety of the vaccine during pregnancy.
So we know that once again, during the Sisonke trial, the Johnson & Johnson, people are advised to rather not have the vaccine during pregnancy. But once again, the American College of Obstetrics and Gynecology says the Pfizer vaccine is safe to have during pregnancy. And we ourselves have seen people who have not been vaccinated, who are pregnant, who are extremely ill and have succumbed to the virus. So it's a no-brainer.
Breastfeeding?
Breastfeeding is the same. You should have the vaccine even if you're breastfeeding. Remember, when a mother breastfeeds, she transfers her own antibodies to the child as well. So even more so, she can transfer those antibodies.
Right. There are lots of questions around the different phases of the rollout. I just want to be clear that you might be able to answer some of them, but this isn't your field. This podcast is really about the medical aspects of it, not when people will be able, when the under 60s will be done, etc. A lot of people are asking about the time difference between the first and the second. We have discussed that before. I think you said it's now been moved to 42 days and you are comfortable medically with that. Again, we're not commenting on the policy. We're commenting on this podcast, not on politics, not on policy. We're commenting on the medical aspects of it.
So you're 100% correct. We don't make the policy drafts or we don't make the recommendations to government. Although I think we should. I think we'd do quite a good job.
I think so as well. I think we're very sensible between the two of us.
100%. And from our listeners, we get good advice, But the point of the matter is that we're very happy with 42 days between vaccinations. In fact, people who were told initially 3 weeks are now being told that they are moved to 42 days. And I recently read an article that in the next week to 2 weeks, teachers are going to be put on the priority list to be vaccinated as well. So we need our essential workers vaccinated as well. And we need more pilot sites and we need more sites where people can be vaccinated. It's so important.
Yeah, I did record a podcast earlier last week with Discovery. If you do want information around that, it's on the same YouTube channel. Go and have a look at that. You'll get a lot of those answers there as well, if perhaps you missed that. All right, just taking a look at a few people asking, we'd love to vaccinate our staff. Again, these are questions that we're not going to be able to answer in this.
Well, we can answer them, but it's just not the answers people are looking for. We'd also love you to vaccinate your staff. I'd love to vaccinate everybody. Absolutely. We need people vaccinated. In fact, I can't wait till we can get our 12 to 15-year-olds vaccinated and our 15 to 18-year-olds vaccinated as well. But we've got to go according to the rollout, unfortunately.
Yeah. And again, just your comments on that, because they've seem to have done away, and a few people have asked about that, with the comorbidity aspect of it, and they're only working according to age. That is not something that you agree with. Am I right?
I still, it boggles my mind. I'm flabbergasted. I mean, you've got somebody who's over the age of 60, who's got multiple comorbidities, and then you take somebody who's well, who's fit, who's got no comorbidities, and you're going to prioritize that person over somebody who can get critically and severely ill. It makes no sense. I've always said from the beginning, they should have given a scoring system. The more comorbidities you have, the higher your age, and the higher the amount of your score should be, and those people should be prioritized and go down the line from that. But unfortunately, that wasn't done.
The reality is that people with these comorbidities generally have a specialist that could verify that, who could, they could have a standardized notification. It can't be that everybody with flat feet has a comorbidity, but there are ways to monitor.
It's not every bald man doesn't have a comorbidity.
Well, we've already established some weeks ago, months ago, that baldness is, which is why I'm a little upset by this whole thing, but that is something completely different. All right, and on last week's podcast, according to Zilla, we spoke about the fact that the J&J, various countries recognizing other vaccines, and I just think we should clarify that. You didn't say that Israel won't recognize the J&J.
No, I didn't say that. I said that Israel are using the Pfizer vaccine only. So that's the only vaccine they've got experience with at the moment, and that's what they're happy with at the moment. You need to discuss if you want to go there, if they're happy to accept it. I don't believe at this point in time that it makes any difference whether you've had the Pfizer or the J&J vaccine. If you're going to Israel, they're still going to put you in quarantine for 2 weeks regardless.
All right. And I just wanted to go to Joan's question because I think it speaks to a lot of people who are trying to be as careful as possible. Please can you ask, excuse me, Dr. Anton Meyberg, if we should ask our domestic staff who's not live in rather to stay at home until this wave is over. Is this wave far more serious than the other two? And has it been exacerbated for winter? Any other suggestions as to how to protect ourselves?
Look, I think we're in a precarious position. We're only on kind of level 2 at the moment. We're not in a level 3, level 4 lockdown, and the country's still moving forward. People are still going to work. There's not major lockdown, so you can't really restrict a non-living domestic worker from coming to you during this time. What you can do, however, is ensure that they wear a mask, that they sanitize, that, if they're coming to you, you can try to get them to you without having to go in a public transport system where you can make it as safe as possible for them to come to you. And when they're at you, don't stay in the same room if you're worried about it, and keep on sanitizing and keep on washing things. That's the best you can do at this point in time.
Mm-hmm. So I think just try and be as careful as possible without making yourself mad as well, because we do have a road to go still. And I can tell you the one thing that I'm observing is that people are struggling mentally and emotionally. I mean, I know you are because of emotionally, because of some of the things that you're dealing with, but even people that aren't dealing with the stuff, staying home, not socializing, this anxiety, hearing about deaths of people in the community, it is very, very unnerving and destabilizing in a way.
Yeah, look, it is. There's just too much negativity going on at the moment, and we've got to try and boost people up in certain ways, but people have just got to actually take the responsibility.
Is there anything that we could do to help you, to help our medical teams, to help our teachers, people that really are facing this every single day?
It's very simple. Follow the rules. If you follow the rules, and the rules that were made, the non-pharmaceutical intervention rules, wash your hands, social distance, don't have sleepovers, don't have parties, obey the rules, that will help us. Prevention is better than cure. It's the old adage. If we prevent people from getting sick, we won't have the problems that we're dealing with at the moment.
All right, one more question before we wrap this all up. Tell us about schools. How are we doing there, and what's likely to happen?
I think we're doing pretty well at schools. The schools have got their finger on the pulse. They're aware of what's going on. They're trying so hard to keep open, but they're only keeping open if they're sure there's no inter-school spread or there's no probability of inter-school spread, and they're making sure they're keeping it safe as possible. Funny enough, I did a spot check at one of the schools this week, and I was pleasantly surprised at how well it was run. Kids were wearing the masks. Teachers were wearing the masks. I went into one of the staff rooms.
Did you go undercover?
I did actually go undercover. I didn't tell anyone I was coming. And I felt like a bit of a spa. It was quite nice. But I saw everybody like go over there. But it was really refreshing to see how well these schools are doing at this point in time. And we know we've got this, most of the high school kids are starting exams in the next day or so, or next week or so. So that's already going to curtail your numbers and cut the numbers down at the schools. And that's going to help dramatically as well. Obviously, the primary school is a bit different, but we've always felt that the primary school kids are the most responsible of the whole schooling system. So hopefully we can keep open for another 3 weeks and then go on holiday and recharge.
All right. Is there any good news?
So at the risk of catastrophizing and being quoted as being negative and the prophet of doom, God forbid, unfortunately, with the soccer season over, there's little good news. We can't spread much good news this week. So It has been a heavy week. It's been a really heavy week with people critically ill and people having lost loved ones. And we now need to change the sort of the conversation. We need to bring out the positivity. We can figuratively hold each other up. We need to be kind. We need to drop off gifts at people who are in isolation. We need to send messages. We need to show people that we care. And most importantly, more important than any of this, we just need to stay safe. Safe that, please God, we can go back to honest and real good news reporting in the next few weeks. And to quote, stop waiting for Friday, for summer, for life. Happiness is associated and achieved when you stop waiting for it and make the most of the moment you're in for now. Be safe and have a good week.
Dr. Anton Meyberg, thank you as always. I really do hope you have a better week than you had last week. I'm Howard Feldman. This is the Sunday Synthesis podcast. Don't forget to subscribe below. Keep sending us your questions. Thank you for your incredible support for this podcast. It's really your questions, your feedback absolutely blows us away. More important than anything, try and be positive. Find the good things. Don't immerse yourself only in this. And whilst you do that, make sure that you are safe, that everybody around you is as well. Have a fantastic week. God bless.